Hi, this is Professor Sanders. I'm going to be recording lecture number 3 here on congestive heart failure. Sorry it's late, guys. I recorded it. It did not save. I cannot believe it didn't do that. So it's going to be just a little bit late getting out to you. All right, let's get started. Objectives. I'm going to go over terms, concepts. I'm going to skip over fun facts. I'm also going to skip over. So let's get right into it. Let's talk about what is congestive heart failure. I'm going to let you read through this. This is just a basic definition of what congestive heart failure is. However, I do want to point out that it can be either right or left-sided heart failure. And it could be primarily it's going to be either a problem with the contraction or a problem with the filling. But regardless of any of that, the ultimate result is that heart failure is the inability of the heart to pump out enough blood to meet the metabolic needs of the body. Let's talk about right-sided versus left-sided heart failure. Starting with the right side, I just want to point out and talk a little bit about the anatomy of the right heart, just touch on it a little bit. When we talk about the right ventricle, that muscle is significantly smaller in its size, not size, but thinner. The wall muscle is thinner, and it has reduced or less elasticity than the left side. And this is because it doesn't have to contract hard or work hard in order to overcome resistance to pump blood out. So because of that, the right ventricle has less blood supply and, again, less elasticity, less contraction. The right ventricle is what we call preload dependent for filling. In other words, if you don't have your preload or you don't have fluid coming in, you're not going to fill up and you're not going to pump it out. That's basically what that means. And the right ventricle, because it doesn't have strong contractility or strong elasticity in there, where it doesn't have that good force, it's more susceptible to increases in the afterload. So things such as increased PVR, pulmonary vascular resistance, anything coming from that left side that's going to cause increase in pulmonary, hypertension and all that pulmonary vascular congestion. It's going to increase the workload on that right ventricle. And the right ventricle is just not really equipped at moderate changes to really overcome that. So you're going to have a significantly reduced right ventricular stroke volume or cardiac output because it just doesn't have the strength to overcome that. All right, let's talk about causes of right ventricular heart failure. The most common cause of right ventricular heart failure is left-sided heart failure. So what happens in left-sided heart failure? The blood backs up into the lungs, into the pulmonary vascular system, and increases our pulmonary vascular resistance, and thereby the right side of the heart has to work harder to overcome that. And this usually happens more in patients that have chronic congestive heart failure versus acute, but it can happen in acute, mostly in chronic though. Other conditions are going to include pulmonary artery hypertension or pulmonary PAH or pulmonary hypertension. And again, what that's going to do, it's going to increase that afterload, right? The pulmonary vascular resistance is increased, and the right side of the heart has to work harder, expending more energy and to overcome that resistance to pump the blood out. And that again is more of a more of a chronic problem and slower developing than it is an acute process. Pulmonary embolism can also restrict the blood flow into that lungs, increasing that pulmonary vascular resistance, or PVR, increasing that pressure, so the right side has to work harder for that, and that's an acute process. And then mitral valve disease with secondary pulmonary hypertension. And again, the mitral valve is going to, cause that pulmonary hypertension, and that goes right back up to here, okay? Acute respiratory distress syndrome, ARDS. This is something that with winter coming up, you may see in your clinicals, and what's going to happen is In ARDS, their lungs are get real stiff, less compliant, and it increases that resistance. So the right side of the heart has to work harder to overcome that. And again, if you look at all of this stuff, this is all relating to the pulmonary vascular. This is all that pulmonary vascular, right? High pressures in the pulmonary, so in the lungs. And then, of course, we have a right-sided infarct. And then a right-sided infarcts can happen even though they are less common. And I think one of the concerns that I have with a right-sided infarct is that because you have less vasculature in there, a small amount or small blockage could cause, I think, substantial damage to that, thereby decreasing the right ventricle's ability to contract, right? Dead cells just don't work, right? So those are some of the causes of right-sided heart failure. We also have other types of causes that would be more, and these are all resistant, okay? More or less contraction and resisting and the force that it has to overcome. But then we have filling impairments. And that means that we just said that the right ventricle is dependent upon its preload or its ability to fill. So anything that's going to constrict the right atrium or the filling of the right ventricle is going to cause that decreased cardiac output. So the heart's going to have to work harder, right? Expend more energy, and it's going to cause more damage. And some of these can happen from pericarditis or tricuspid stenosis. And again, what is it doing in tricuspid stenosis? The blood's trying to fill with it's trying to go through a small hole, right? The valve's not opening up fully and letting all the blood from the atrium go right on down into that ventricle. So it's not filling. That ventricle is not filling. Thereby, it's not pushing it out, and you have decreased cardiac output. Systemic vascular shock can happen, and this can be, you can think about your sepsis, in sepsis, what happens there? Well, we got all this vasodilation going on. We got third spacing going on. So we got blood volume we got volume in the body. It's just not in the pipes, right? So you got less filling, right? Less returning back to the heart. And that also happens with hypovolemia. So filling, if it doesn't fill up here, it's not going to go out. If it's blocked, if the road's blocked, it's not going out. All right, let's talk briefly about forward and backward effects. Let's make sure you ingrain these into your memory because these are all over the place and you see this very frequently. When we talk about a backward effect, think of it as before the heart, kind of opposite, right? Afterwards effect, it's just what it says, after the heart. So before the heart and after the heart. So when we talk about the right-sided heart failure, like I said in class, the venous system is a little bit more pliable. Those veins are more pliable than the arteries, so they can hold more blood volume and stuff, and they can stretch out. So when the right side of the heart is failing, the blood's got to go somewhere. It's not pumping it out. It's trying to go in, but it's not going out. So it backs up, and where does it back up into? It can back up into the liver and the spleen and all that. So we can get hepatic megaly. We can get ascites, splenomegaly, and then we have other GI symptoms such as anorexia. Okay, the fluid can leak out because of all this congestion going out into the peripheral and stuff, and it can leak out and cause peripheral edema. And then we can also see it back up into the jugular, where we see the jugular vein distension. So anything before the heart is the way I like to think about this. Afterwards effect is going to be going away from the heart, right? So if you have a decreased cardiac output, you're not getting enough oxygen out to the body, to the muscles, so you're going to have fatigue. Your renal arteries are not getting, your kidneys are not getting enough blood, so you're going to have a low urinary output. Your heart rate's going to go up, right? Your body's going to try to compensate and say, hey, I need more cardiac output here, right? And it's going to cause your heart rate to increase. So you'll see an increased heart rate. And these are neural responses, your increased heart rate and your faint pulses, restlessness. These things are kind of your neural response here. We'll talk a little bit more about that. So the neuro is going to, your body says I need more blood. It's going to increase the heart rate, and it's going to cause vasoconstriction, peripheral vascular constriction, right? Because it's going to try to divert the blood up to the vital organs. So that's where you're going to get these faint pulses. So thin, fretty, faint pulses. And then because you're not getting enough blood returned back up to the brain and everything, you're going to have restlessness, anxiety, and confusion. Please memorize these. Okay, let's talk about the left ventricle. So the left ventricle pumps against a higher pressure. And because of that, that muscle has to be thicker and stronger because it's going against, if you think about your blood pressure, you're going against your peripheral vascular, your systemic vascular resistance. The way I kind of think of that is that if you think about your pressure in your normal blood pressure, say 120, I don't know, over 60, versus the right side who's pumping against pulmonary vascular pressure of 20 to 30 on your systolic. You can see why the heart muscle has to be stronger. So it's going against a higher resistance. And left ventricular, the wall is a lot thicker than the right side, and it has more elasticity. So it has more strength, more ability to contract and squeeze that blood out forcefully to get it against that, away from that, that resistance, right? Push it out. And just like the right ventricle, it's preload. The preload, well, let's talk about this. The preload of the left ventricle is directly related to alterations in the right ventricle. So what this means is that if the right ventricle is not doing its job and not filling, the ventricle is not going to get enough blood in, so it can't push it out, right? And like we just said, the afterload effect is going to be affected by your systemic vascular resistance. Okay, how much does it have to fight to get out to the rest of the body? So because it goes against that higher pressure and the wall's thicker, it requires more oxygen to sustain it. So you're going to have higher vasculature in there, more coronary arteries to feed that because it requires more, it consumes more oxygen because it works harder, and therefore you're going to have more arteries and supplying that that left side of the heart. Causes of left heart failure. There's a lot of mechanisms that can cause left-sided heart failure. One of the biggest ones and a predominant one is either chronic or poorly controlled hypertension. So what did we just say? That left side of the heart has to push against that resistance. So when you got hypertension going on, you got a higher systemic vascular resistance. Thereby the heart has to work harder, expend more energy, and it can lead to heart damage and cell death and a reduction in your ability to contract because of the dead tissue. Coronary artery disease. Excuse me. So coronary artery disease causes ischemia, direct ischemia damage to the myocardium, leading to what we call remodeling and scar formation. And what this does is it's going to decrease the contractility of the heart, so the heart's ability to squeeze that left ventricle, and ultimately it's going to decrease the cardiac output. If you can't squeeze it out, it ain't going anywhere. It's just going to sit there and do nothing. Let's talk about arrhythmias. So some of the arrhythmias can cause left-sided heart failure. And you think, how does that happen? Well, let's think about it. If your heart isn't beating, if your heart rate's too fast or your heart rate is too slow, you have reduced cardiac output. If it's beating too fast, you don't get enough filling. It doesn't have enough time to fill that ventricle up to push it out. Okay, so you don't have enough cardiac output. If your heart's beating too slow, it's rate, you know, it has filling, but it's just too slow. It's just taking its sweet old time and it's not doing. But regardless of that, either one of those, it causes ischemia to the heart, right? And that ischemia to the heart is what causes the damage, the tissue, cell death and tissue damage, okay? And the reduced ability of the ventricle to contract. And then, of course, we have ischemia and MIs. And the MIs is left ventricular heart failure is directly related to the MIs due to the injury. So again, cell death. So when you look at this stuff, really you're looking at tissue death. So coronary artery disease leads to ischemia, tissue death, MI, and all that leads to ischemia, cell death, arrhythmias, whether too fast or too slow. You have a decreased cardiac output. The heart speeds up, tries to work harder, still doesn't get enough, and you have that vicious cycle that goes on where there's just that slow progression of damage to the ventricle, decreasing the cardiac output. Cardiomyopathies are another area. These can be either congenital or of unknown causes, but for whatever reason, it's the ventricle's not going to either be able to relax enough to fill, get enough blood out, or it's going to have less ability to squeeze. And then aortic mitral valve disease, because that creates what again? That higher pressure, that higher resistance that the heart has to work again. So the heart has to work harder and faster, requiring more oxygen, and it doesn't can't get the cardiac output. So backwards and forward effects. Again, memorize these, please. Backward effects is anything before, I said before the heart, but it's before the heart, the failed chamber, I should say, maybe. So a backward effect, so what happens? Well, in right-sided heart failure, we said, because the blood's coming from the systemic into the right side, it goes and backs up throughout the venous system, right? But on the left side, the blood's coming from the pulmonary into that left ventricle, or that left side of the heart. So a backward effect would be going into the lungs. So anything respiratory is going to be a backward effect. So it's going to cause increased shortness of breath, orthopnea, right? You're not going to be able to lay flat. You're going to have a cough. They're going to have that proximal, nocturnal dyspnea, where they lay down. That blood returns, it overloads that left ventricle because now you got too much blood going in there, and they wake up feeling like they're drowning. They can look a little cyanotic. And then when the blood or all that backs up into the lungs, it's going to leak out a little bit, and it's going to cause that pulmonary edema, so you can get crackles that are going on there. So it's before the chamber or before that left side. So that would be all your respiratory. A forward effect is anything after the heart. What's happening before? Well, if you look at this, you're going to see that this is the exact same symptoms that you're going to see in the right-sided heart failure. You're not pumping out enough blood to meet metabolic needs, so you're going to have fatigue. You're going to have that decreased urine output. Heart tries to compensate by increasing its heart rate. You're going to constrict down. You're going to get reduced pulses, restlessness, confusion, and anxiety. Please remember these. I put this in here. Please click on it. This is going to really give you, these are short videos. They're really great on helping to distinguish and right-sided versus left-sided heart failure. And then I also have the systolic and diastolic heart failure in here as well. So these are only maybe about 5 to 10 minute videos. I think one's 10 minutes, the other two are 5. But I'm telling you, they're really good videos that'll help you understand the whole process a little bit better. So please look at these when you have a chance. So speaking of systolic and diastolic heart failure, let's take a look at it and try to distinguish between what's actually happening with these. In the center, you can see we have the normal heart, and we got a nice heart muscle, and the chambers are really good size. So You know, we got a good squeeze going on here at 60 to 70%, good filling, got good cardiac output. But look at the systolic. What happens in a heart with a systolic dysfunction? That muscle is thin and it's stretched out. It's lost its ability to squeeze. Systolic or systole is your squeeze, your contraction. So the systolic is going to refer to your ejection fraction. Can I push it out? In comparison, when we look at that diastolic dysfunction, you can see we've got a thickened or a heart muscle here, or the inability of that muscle to relax enough to open up like this. So you've got a filling problem here. So systolic is going to be a problem with your squeeze. Diastolic is going to be a problem with your filling. So when we talk about the systolic heart failure, this is going to be heart failure with reduced ejection fraction. And I can't stress that enough. This is reduced ejection fraction. That means you don't have that squeeze. And its biggest characterization is that your EF is going to be less than 40%. So again, it's the most common type of the heart dysfunctions that you're going to see, or heart failure that you're going to see. And it's where the left ventricle, loses its ability to generate enough pressure for the blood to eject the blood forward and overcome that resistance, right? So again, systolic equals contraction. Think of this as the force. Some of the causes, blood supply, such as in coronary artery disease. If the muscle's not getting enough blood to meet its demands, it's going to have cell death, and thereby you're going to have some scarring, and all these things are going to happen. It's going to lose its contraction. It's not going to be able to squeeze, right? Dilated cardiomyopathy, where that heart gets dilated out, you know, stretched out. It can't squeeze. Valve diseases. Most commonly would be your regurgitation, would be mitral valve, or your tricuspid regurgitation. Okay, and what it's doing is it's causing that tissue damage, you know, tissue and cell death, such as and even your stenosis, where it's working against that higher pressure. It has to work harder to get out, right? And then you have arrhythmias. Any arrhythmia that's too fast, too slow, or uncoordinated, okay? And so you can think about sinus brady, any of those rhythms like that, or symptomatic bradycardia, well, any bradycardia, heart blocks, any of those types of things, right? It decreases your cardiac output, and thereby it decreases the blood supply to the heart, and the heart can have cell death. And likewise, rapid heart rate as well, such as an atrial fib and your SVTs. It's squeezing so fast, it doesn't allow the heart to fill properly, and that decreases your cardiac output. And when that happens, blood's not getting to the oxygen demands of the heart aren't being met, and you have cell death. All right, diastolic dysfunction. In diastolic dysfunction, this is better known as heart failure with a preserved ejection fraction. And this one I think is a little bit confusing for some nurses, because when you get report from on your patient and they say, oh yeah, they got a CHF, they got heart failure, and I'll say, oh, what's their EF? And they'll say, oh, their EF is 55% or 60%. I'm like, well, how can they have congestive heart failure if they've got an EF of 50 or 60%? And that's because it's preserved ejection fraction. So you got the squeeze there, okay? But the problem is coming from the inability of the ventricle to relax or open up enough to fill, right? So it doesn't fill during diastole. So when it's supposed to be nice, it can be stiff or whatever, and it just doesn't relax. So you can see it's just smaller amount going in, smaller amount going out, regardless of that squeeze. If that squeeze is there, but if you don't have enough going in, I don't care how much that squeezes, you can't get more out than what you put in. So the key thing in this is that the ejection fraction, the EF, is usually not affected. So they can have a low, but trending in that normal range or in the normal range. So what causes a decreased cardiac output? Well, like I said, it's a filling problem. The ventricle cannot relax enough to fill. So you don't have that preload. So this is your preload. So let's talk about some of the causes. We have hypertension. Chronic hypertension is usually one of the big problems, and that's where the vessels are clamped down, creating more resistance, and the heart has to work harder to get through those vessels that are small. And since the heart is having to pump harder over that resistance over time, what am I saying? The heart muscle, I'm sorry, the heart muscle is going to have to thicken up and grow a little bit more to try to compensate for that and overcome that force. So the heart can get thicker. So chronic heart failure, okay, or hypertension, I'm sorry, hypertension. And then stenosis, pulmonary aortic primary aortic stenosis. So your aortic valve, right? It's right there. If that is narrow, it's not, right? Can't pump out. The heart has to work harder, requiring more oxygen, and that muscle can thicken, and thereby overall decreasing its ability to fill. Restrictive cardiomyopathy, dead cells, right? The dead cells can cause scarring and thickening. Diabetes can cause your heart, that muscle to thicken up. And then, of course, the coronary artery disease, again, blood flow, feeding the heart, okay? These are all common causes of the increased demand on that left ventricle, and it causes a decreased filling. And then obesity and inactivity. So basically the heart's going to have to work harder to overcome the resistance, and in time, like anything else, it's going to cause muscle thickening. Compensatory mechanisms. So how does our body compensate when we have heart failure? I guess I should have started with the sympathetic nervous response first, because that one happens. So let's talk about the sympathetic nervous response. When you have a decreased cardiac output, our sympathetic nervous system kicks in and it says, hey, I need more blood, right? So what is it going to do, and how's it going to do that? Well, it's going to cause your heart rate to go up. If I beat faster, I can get more out. But when it does that, it's going to constrict, right? Because what it's trying to do is going to constrict those vessels, and it's going to try to get that blood back up to the brain and all of that to feed the brain and everything. So you're going to have a faster heart rate. You're going to have constricted vessels. And in the end, what that does is it actually contributes to more heart failure, like we talked about with the forward and after, forward and backward flow problems, right? So it's this vicious cycle that goes on. More demand, it's going to increase your O2 demand and ultimately decrease your cardiac output in that. So once that sympathetic nervous system kicks in and it constricts those vessels, your renal is affected, okay? And the renal, the RAS, is a complex system and helps regulate your blood pressure and fluid balance in the body, and it involves a series of chemical reactions that ultimately lead to the production of your hormone called aldosterone, right? And aldosterone helps to retain sodium in water, which is going to increase your blood volume and raise the blood pressure. So now you've got constriction going on and increased volume going on, and you can't get rid of it. So the RAS is going to contribute to, it tries to compensate, it holds on to more fluid, thinking it needs more fluid, and then ultimately the heart has to work harder to get that off. So, yeah, increase blood volume, this and that. Okay, ventricular remodeling. So, or cardiac remodeling. Okay, so over time, an overactive RAS can cause the heart to undergo structural changes, and this is called the cardiac remodeling. And it's scarring, and this can lead to a decreased cardiac lead to a decrease in the heart's ability to pump blood efficiently. Okay, so the RAS is going to cause those changes, right, and it's going to just contribute to the problem, right? So now we got three things working against us. Thought I had more on that. Talked about the CNS, heart. Okay, let's just move on. All right, I'm not going to go through this too much, but this is the New York Heart Association classification for the stages of heart failure, the NYHA. And what this does is it just shows you that we've got four different classifications of four different stages of heart failure that occur in a patient. And obviously it's going to go from mild to where there's no symptoms, really no limitations, all the way up through severe symptoms and end of life stages, actually. So read through this when you get a chance. Okay, let's look at just quickly what is acute, the difference between acute and chronic heart failure. Simply put, chronic heart failure is a slow process that develops over time and will continue to progress over time. So it's that slow development. And that's where you see these chronic hypertension, poorly managed patients, okay? These patients are the ones that will have that chronic heart failure. And in the acute, like I said, it's a sudden onset. It's exactly what it says. It's in most cases it occurs suddenly, and this is where your medical emergencies really come into play quite a bit. Measure over time. One thing that we need to remember is that regardless of whether it's acute or chronic, the symptoms can very much be the same: shortness of breath, fluid, the shortness of breath, fluid overloading, fluid building up, chest pain, all of that stuff. And when it's really acute, it results in that pulmonary edema. Okay, whew, we're getting there. All right, hemodynamic monitoring. All right, let's talk about lab tests and lab values. We're not going to get into too much specifics on it, but we're just going to discuss some of this. When we talk about hemodynamic monitoring, most of the time I want to think about is the Swan-Ganz, and we're going to get all that wonderful information, or systemic vascular resistance, or PVR, all those great numbers of all of our heart and everything else. But that's not what generally happens with CHF patients. Majority of these patients that come in with congestive heart failure, those that are in acute, chronic, it doesn't matter. Majority of them do not have hemodynamic monitoring, such as Swan-Ganz. So how do we check the hemodynamic monitoring? Well, one thing that is invasive that we can use is our central line, and then we can get our central venous pressure. And that'll give us an idea of our fluid, whether we have too much fluid or not enough fluid going into the body. That's one invasive thing we can think about. But most of our hemodynamic monitoring is actually going to come from our physical assessments of the patient. Okay, do they have edema? Do they have shortness of breath? All those signs and symptoms, those forward and backward effects that we talked about, are going to be part of that. Do they get good urine output? You know, all of those things are how we monitor the hemodynamics and stuff. Our blood pressure, even our blood pressure running, you know? So all of these things are part of how we can monitor the hemodynamics, but a lot of them is indirect monitoring versus that direct. Some of the hospitals, we do have, if they have like an arterial line and stuff, we can use a non-invasive type of hemodynamic monitoring. We have those over at St. Bernardine, or St. Bernardine's, I'm sorry, St. Mary's. But as you'll see, we don't use them that often, mostly in the open hearts. And then we're having equipment problems, so indirect monitoring is probably your best bet. We can also check, we can do some cardiac output studies. And this things, we can do is we can look at our echocardiogram. And that echocardiogram is really your gold standard when it comes to diagnosing congestive heart failure, right-sided, left-sided, it doesn't matter, systolic or diastolic. And what this is it's that ultrasound of the heart. And it could be either the external echocardiogram or they could even do the TEE if they need to. But generally we just do the echocardiogram. And what this is going to do is it's going to allow us to be able to measure the pressure in all those chambers. It's going to allow us to look at the heart valves, whether we have any stenosis going on, any regurgitation going on. It's going to let us look at the muscle of the heart and the motion of the heart. How well is it contracting? It's going to let us measure that ejection fraction. How much blood is it pumping out? So the echocardiogram really gives us a lot of information in regards to the diagnosis of a heart failure patient. Some other tests that you may see would be therapeutic drug levels. Mostly this would be referring to patients who are on like digoxin to increase the contractility of their heart, right? Help slow it down a little bit, help improve that cardiac output. And then patients that may be on anticoagulants, if they're in atrial fib, coagulation studies. So those are the levels there. Other labs that we're going to look at are CBC, electrolytes, urine creatinine, liver function test, and your BNP. I think it's funny because when we talk about the CBC, it's like, why do a CBC? Well, your patient's on anticoagulants. They can affect your platelets. So you might want to know what that is. That's a good indicator of how well your therapy might be working. Is your blood too thin or is it too thick, right? And then most patients that have congestive heart failure are going to be on some sort of a diuretic to help offload and get rid of that excessive fluid. And a good portion of these are potassium wasting drugs such as your Lasix. So it's important to continue to monitor the potassium and your electrolytes, your potassium and your magnesium, because if those levels go too far down, then you can have additional arrhythmias, thereby decreasing your cardiac output even further, or you can even go into lethal arrhythmias. So it's important to monitor those. BUN and creatinine, as we said, one of the compensatory mechanisms that we have is that that sympathetic nervous system is going to kind of constrict those vessels. It can decrease that renal flow to our kidneys, and our body's trying to hang on to it so we can go into an acute renal failure. So we want to make sure that we are checking to make sure that our renal function is staying good, or if it's trending up. And if it's going up, then we need to make sure we're letting the doctor know, because again, we might need to start diuresing them, and we want to catch that early enough where we can turn it around and they don't go into a long-term renal failure. Liver function test. That liver function test, when would we do that? Well, we said right-sided heart failure can affect the liver, so liver function test to address and monitor how well that liver is holding up, how much damage do we got going on. Just like we would be checking our kidney functions in heart failure, we want to check the liver function as well. And then we have the BNP, and I love the BNP. This came out when probably around somewhere around 2000, 2001, sometime in that area, we started using it more. But when we diagnose and look at patients with congestive heart failure, we mostly relied on chest x-rays prior to 2001. And the problem with that is on chest x-rays, sometimes it's hard to distinguish between pneumonia and vascular congestion. So we were happy when this BNP came out, because this is cardiac specific. And then if it's elevated, we can see that we have heart failure going on versus a pneumonia. And nowadays, we just use this pretty much as a standard, and we look at how high or how low those levels are to help us judge the severity of the heart failure. ABGs are good to have when you have patients that are having left-sided heart failure and everything, and they're not oxygenating well enough. We need to know what the blood gases are. Patients with chronic congestive heart failure, especially that left-sided heart failure going on there, they may require home oxygen, so ABGs might be indicated for them prior to discharge to evaluate them for home O2. And then again, coagulation studies. Okay, so now that we've talked a little bit about diagnosing and looking at our labs and congestive heart failure, how are we going to manage these patients? Well, a good portion of these patients can be managed with medications. And the type of medication is going to just depend on the type of heart failure and the severity of the heart failure. So let's look at a few. Our first one is going to be our cardiac glycosides, and this is going to be DIG. And this medication could be used to help strengthen the heart's pumping action. It's got that inotropic type effect. It's going to increase that contractility. But what's good about this is that this can be used in patients who have developed like an atrial fibrillation or a high heart rate as a result of the heart failure. So this will also bring the heart rate down. So digoxin increase contractility and decrease heart rate, thereby improving the function and the output. Better squeeze, less resistance, you know what I mean? Less oxygen demand, right? It's going to help. Then we have our ACE inhibitors and our ARBs. The ACE inhibitors and ARBs are going to help the patient with heart failure by lowering the blood pressure, widening out those vessels, decreasing that systemic vascular resistance. So that's going to help the heart, reduce the workload on the heart, and help slow down and minimize the long-term damage. While you can't get rid of heart failure, you can certainly kind of stop it and prolong the long-term or worsening effects. And some of that would, the ACE inhibitors would be the captopril or captopril, enalapril, lisinopril, vestoril. And then as far as the ARBs, we have orstatin and Diavon. Another classification of drugs that we would typically see on patients with heart failure are diuretics. And as we said, in one of our compensatory mechanisms is for that to hang on to that fluid, right, through the RAS, right? Hold on to extra fluid. Well, that extra fluid's giving us more problems than what we need. So what we got to do is got to get rid of it. So we'll give the patient diuretics to help them get rid of that excessive fluid. And what this is going to do is it's going to decrease the workload on the heart and decrease any potential fluid backup into the lungs. And this would include medications such as furosemide or Lasix, which is Lasix. You can also see maybe Bumex. And then patients, I think that are in the earlier stages, would be using like the hydrochlorothiazide, which are the HCTZ. And this is kind of nice because it gets rid of excessive fluid, lowers the blood pressure, but it's more for earlier stages than it is later stages of heart failure. Beta blockers. So beta blockers, what are they going to do? They're going to increase the contractility, give extra squeeze to that heart, right? And these can help lower the heart rate as well. So a good example is Coreg, which is carvedilol. Then you have other medications such as atenolol, labetalol, and metoprolol, or low pressure. Low pressure metoprolol, they're the same thing. Oh, did I skip? Oh, I skipped inotropes. Sorry. So inotropes. So some of the inotropes, well, inotropes would include like dopamine, dobutamine, epinephrine, and then I think DIG is also an inotrope as well. And what that's going to do is it's going to increase the contractility. So it's going to increase the squeeze, give it extra squeeze, right? Get that to pump out more efficient. And then other medications that you're going to typically see, which are not on here, I didn't put on here, I don't know why, calcium channel blockers. So remember we said we had that diastolic dysfunction and the heart doesn't relax enough? Well, the calcium channel blockers is going to help by relaxing that muscle to allow it to fill more. So calcium channel blockers can really benefit some of the patients. And I thought I had a, yeah, and it's going to reduce the workload on the heart, right? Get better fill, better output. A couple of other medications that you're going to see that are not listed here that relate to heart failure is going to be your potassium, right? When we give we're diuresing, we're going to make sure we're watching those electrolytes. So patients may need potassium supplements for their management. And then oxygen is also a classification of medications, considered a medication that patients can be home with. And like I said, that's usually getting more advanced stages of your heart failure. Okay, that's going to lead us into acute pulmonary edema. So we talked about the left-sided heart failure, right? And we talked about the backward flow, right? It's going to back up into the lungs, right? So when you have pulmonary edema, it's a very acute process. It can come on very quickly. Sometimes it can come on in a matter of 5 to 10 minutes. And sometimes it could actually take a couple hours, but regardless, it can lead to, it's a life-threatening condition, okay? It's acute and a life-threatening condition. And that's because the left ventricle is not pumping the blood out and it has to go somewhere more is coming in and it's backing up into the lungs, preventing you from oxygenating. Some of the signs and symptoms that we're going to see with that is a shortness of breath, sudden and acute. We're going to see shallow, rapid breathing. Hypotension or hypertension can occur. Either one can occur. Sometimes they initiate their blood pressure. We lose their blood pressure. And then sometimes when they're trying to compensate, we'll see that initial rise when they're in real distress initially. And then, so yeah, I usually see their blood pressure go up before I see it go down. But either way, it can cause either hyper or hypotension. And the patient's going to be generally appear to be pale, diaphoretic. They're very anxious. Their anxiety is very, very high. And you're going to hear all those crackles going on in the lungs. You might hear wheezes at that time. Or you may have very, very severely diminished lung sounds altogether. And then you're going to see a pink frothy sputum. They might be coughing up pink frothy sputum. If they're coughing up that pink frothy sputum, they're in real trouble. And what we're going to do is we're going to actually get a chest x-ray on that patient, and we're going to look for that vascular congestion, okay? And you can also see in a large silhouette, but I think it's more or less the pulmonary vascular congestion is more of what I'm looking for versus any cardiac enlargement. So here's a couple of chest x-rays we're going to look at real quick. And this is what congestive heart failure, or pulmonary edema, I should say, is going to look like on your chest x-ray. And you can see all that white cotton candy fluff going on, fluff. Call the doctor and he says, "What do you see on the x-ray, Lois?" I say, "It's fluff." He said, "Give him some Lasix." I said, "Okay." So what you're seeing here, if you look really close, did you see all of this? This is your vasculature, and that's your vascular congestion. That's the vascular bed. So this is a patient with CHF. Not too bad, but moderate bad. This patient needs to have that fluid removed with Lasix. Usually give it about 20, 40, and get that fluid off, and you can improve their breathing pretty quickly. Usually within an hour, you can see a significant change as long as they respond to the Lasix. Sometimes they do not. You can kind of progress more into this. This is a more severe pulmonary edema, so you can see a lot more going on in here, a lot more vascular congestion. And again, this is because the left side of the heart, here's the heart here, it's not pumping it's not pumping it out to the body, so it's backing up in the lungs. It has to go somewhere. All right, so what happens when you have a patient that goes into acute pulmonary edema? Well, first thing we want to do, call a rapid response if you got a rapid response team or safety net or whatever you may have within your facility. But you first and foremost, you want to do a rapid assessment on that patient. You want to make sure the head of the bed is up so they can breathe. And you want to make sure you pull them up in bed, not just the head of the bed up, but pull them up. You want to bend it at the hips, not up in the chest. When you're down, it compresses the lungs even more, right? So you got to get them high up in that bed. And then we want to check their blood pressure. We want to make sure that they got IV access, 1, preferably 2. We want to start administering oxygen, call respiratory therapy, get them over there, and start them on some oxygen. It can be like an oxymask, just depending on how severe it is. They may have to put them on a BiPAP. And then if it's really severe enough and they're decompensating there, they may have to be intubated. And they want to make sure that we call the doctor. So we're going to do our immediate stuff, start that treatment, get on the phone and call the doctor. We want to also try to make sure we're calming the patient. They have a lot of anxiety, and it's very difficult at times to calm them, and they can get that impending doom going on. So try to calm them as best as you can, because if they're excited, they're going to expend more energy, require more oxygen, which is what they don't have, right? So some of the medications that we can give morphine, we can give Lasix, and we can give analytics. And we can also sometimes we can give them that nitroglycerin to help vasodilate, offload some of that fluid, get it out of the vascular and back out into the peripheral. And then if they're bad enough, we need to transfer them to ICU for closer management. Okay, so when we have patients that are not responding or have a low cardiac output, or congestive heart failure, I should say, low cardiac output, they may need more assistance than what you can get through things such as traditional medications and oxygen therapy. So some of the additional therapies that we're going to talk about is the intra-aortic balloon pump. We're going to touch a little bit on the Impella. We're going to look at ventricular assist device, and then we're going to be talking quite a bit about pacemakers and AICDs, and then we're going to wrap up with surgical procedures such as the myoplasty and transplant. Okay, let's talk about atrial fibrillation real quick. During atrial fibrillation, the top chambers of the heart, or the atriums, loses their normal organized electrical activity, right? And it develops this chaotic, unorganized rhythm in that atrium. So they just sit there and quiver, just kind of just quivering. They're shaking, quivering. And what that does is that's going to decrease the ventricles' filling pressure, right? So it's not filling. It's not filling, so it's not pumping out. That blood it's just, that's what it is. So it's beating too fast, or it's just quivering. So it doesn't have time to slow down, stop, and fill, right? The diastole part of it. It's doing all systole, no diastole, no relaxation for filling. And in the long run, what this does is it's going to cause a decrease in your cardiac output. Patients in atrial fibrillation can either have it can be a fast heart rate, what we call atrial fib, RVR, rapid ventricular response. And like I said, it is an irregular heartbeat. Okay, so we'll look at rhythms on that. So the atrium, again, the atrium doesn't fill properly, so it's not pumping out properly, and that makes the heart work harder. And if this goes on long enough, you're going to have decreased blood supply to the heart, and it's going to weaken the heart, and it's going to contribute to heart failure. So how do we treat atrial fibrillation? Well, atrial fibrillation prior to heart failure, for example. One way we're going to do it is we're going to give them blood thinners, because remember that blood's just sitting in there churning in that atrium, and it's just developing all these little microclots, and they can break loose. They can go up and cause strokes and everything else. So we want to make sure they're on blood thinners, and one common one would be your warfarin, which is your Coumadin. Okay, and remember when we talked about monitoring blood levels, this would be a blood level that you would be monitoring. You want to monitor their INR and their coagulation on that. And another drug that we can use in order to help control the arrhythmias is the antiarrhythmic known as amiodarone. Amiodarone is a great one, and we use this quite a bit. And I really like this because when they have a rapid ventricular response going on, we need to slow that down. Okay, they can only tolerate it for so long, and then their blood, like I said, their blood pressure is going to eventually go down. So what we're going to do in amiodarone is we're going to give what we call a bolus, an initial dose. We're going to bolus them to kind of start getting that blood level up of that drug, that amiodarone drug up. And we typically, we give 150 milligrams. So we're going to give a 150 milligram bolus. It comes in a piggyback, and we run it over about 10 minutes. And then after we do the bolus, we're going to put them on a continuous infusion of amiodarone. And the protocol would be to put them on 1 milligram per minute of amiodarone for 6 hours. And again, that's going to help build those levels and help try to chemically convert them back into a normal rhythm. And then after the 6 hours, we turn it down to a 0.5 milligrams per minute. And depending upon your hospital protocol, a lot of them say times 24 hours. So after 24 hours, we turn it off, or you leave it on until the doctor tells you to turn it off. But either way, it's going to be a chemical conversion is what we're trying to do to the heart, and to get that heart to resynchronize, okay, and get into a normal rhythm. Okay. If chemicals such as amiodarone don't work, we can do electrical cardioversion. And this is just basically what it is. We're going to deliver a shock to the patient to resynchronize their heart. And this is usually done in under conscious sedation. You never want to shock the patient unless they're sedated. So you can give some Versed and have them on monitors, and the cardiologist will come in there. You're going to put all your pads on, and you're going to do a synchronized cardioversion on the patient. So that's going to be delivering the electrical shock in order to try to get them to reset that pacemaker and get them back into a regular rhythm. Another treatment we can do is actually putting a pacemaker in. And this is really kind of cool how this works, because the patients that have this this refractory or this recurrent atrial fibrillation with rapid ventricular response, it comes, it goes, and everything else. So you put them on the amiodarone, then the heart rate goes, they get out of the atrial fibrillation, the heart rate goes too low. You take them off the amiodarone, they go back into the atrial fib with a high heart rate. So what do? Well, let's put a pacemaker in. Let's do both, We're going to put a pacemaker in, and we're going to set it at a, we're going to have our set rate, say a minimum of, let's say 60. So that if the heart rate goes below 60, it's going to work, right? And then we're going to give them the amiodarone. So we're going to give them amiodarone. We're going to let it kick out that atrial fib, and if the heart rate goes too low, it's okay, because the pacemaker will start working. So that's another treatment that we can do. And then we have ablation. And ablation doesn't get talked about that much. So cardiac ablation is when we use that for refractory ablation is a process of going up into the groin, through the groin into the heart, and delivering a radio frequency impulse to a spot that's irritable, I guess is the best way to say it. Okay, so when we have arrhythmias, people can develop additional pathways through the heart. There could be a spot that's just setting off that electrical impulse, and it's causing us to have not to have a synchronized rhythm, right? Or it can cause like a lethal rhythm, like VTAC and stuff like that. So the electrophysiologist will go in, they'll do it similar to a heart cath where they go in through the groin, they put that up in there. Once they've identified the area of target that's irritable, like I said, they basically burn it or scar it, right? And what that does is it causes damage just to that specific spot, and that prevents that spot from firing and causing the arrhythmia. And then, of course, we have AICDs, implantable cardiac defibrillators, or AICDs. And this is going to be what's going to look at shock patients out of that are at risk for lethal rhythms following an MI. They may have a AICD put in to help assist with that. And usually if they have an AICD, it's a pacemaker with an AICD. So who needs an AICD? Well, indicators for AICD would be some sort of structural heart disease that's going to cause a sustained VTAC, right? It's a lethal rhythm. I mean, some people are not symptomatic, but it can only sustain for so long before the body's going to just stop, okay? I mean, your cardiac output's going to go down. Also, patients with syncope that are undetermined origins, VTAC, VFib, all that electrophysio, right? They need that extra, they need the AICD to defibrillate them. Patients that have low ejection fractions and left ventricular ejection fraction, usually less than 35%, due to an MI or due to prior MIs, okay? So when we have that heart, that decreased cardiac or that decreased EF, they're at a higher risk for those arrhythmias, and they can have this be at risk for the sudden death, right? And then they would be candidates for an AICD pacemaker. So let's look at some rhythms here. This top rhythm shows a patient who's in a normal sinus rhythm, and for whatever reason, you went into a sustained VTAC. And that rate is about, let's see, 300, 150, around 200. It looks like it's around 200. So you can see it's just a pumping away. So when you have that AICD in, it's going to detect this rhythm. So we're going along. It says, hey, you're going too fast. You're not following the rules. Boom. It delivers a shock right there. That's your shock. That's your defibrillation right here. And when it does, what you see, I know it's not back up a baseline, but it's coming up. But what you see is that when they delivered the shock, it reset the electrical system there in the heart, right? Allowing for the normal pathway to continue. So it shocked them out of it. So VTAC, shockable rhythm. Remember that. I don't know why I got this on here twice. Oh, I think I was going to have you look at it and decide what it was. So look at this rhythm. What do you think this rhythm is? It's all over the place. Small, unorganized. This is your VFib. Let's go to the next slide. Ha, that's what I did it for. Okay, this is VFib, ventricular fibrillation. This is also a lethal rhythm. You know, patients that are at risk with low EFs, like even 10% is really rare. I really see it a lot. These patients almost always have these AICDs put in. They're at risk for going into VTAC and VFib. Well, this is what VFib looks like, guys. Okay, it's erratic, it's unorganized, you don't see any P waves, it's not regular. So the patient goes into that. Here it is, here's a strip. Here's the shock right here where the arrow is. You can see that shock was delivered. And then you can see it put the patient back into a normal sinus rhythm. You got your P followed by your QRS, okay? And that's what it is. So the two shockable rhythms you want to look for in heart failure is going to be VTAC and VFib. I'm getting tired. Okay, pacemaker modes, types, and everything else. So let's just do a little bit of an overview and talk about pacemakers in itself. Pacemakers can be either at a fixed rate, and meaning that it's set at a standard rate. That's it. You're going to just beat it this fast, and that's it. Or it can be what we call a demand. And the demand is like when you're at rest and you're sleeping, you don't need a heart rate of 80. So we're going to set it at 50 while you're sleeping. But when you get up and you start moving around and you need more, the rate's going to increase, and that's your demand. And it is rate responsive. We got several types. We have either permanent or temporary pacemakers. Okay, and then we have single, double, or triple chamber pacemakers. And let's take a look at it. So this here on the right is a permanent pacemaker. Okay, and there's a generator right here, and this is done down in like cath lab. They'll go in, they'll make a pocket in the muscle up in the subclavian. They put that in, and then they put the leads in. You can see you got two leads. So this is atrial and ventricular. You're going to have one lead going up and attaching into the atrium right here. You're going to have the other one going down into the ventricle. Okay. If this was an AICD, you would have these two leads, plus you would have a third lead coming off, which is your defibrillator. And that would be your triple. Okay. So this is a strip down here, and it's looking at the atrial and ventricular pacing. So the A pacing right here is that first spike right there. And as you can see, you got a spike. It stimulated that the atrium to contract. And when the ventricle doesn't respond in an appropriate amount of time, the conduction doesn't go down and the ventricle doesn't do its own thing, right? It doesn't respond. The V is gonna fire, and that's your second pacer spike right here. So when you look at this, you got two spikes. You got an atrial spike with a P behind it, and a ventricle spike with your QRS, and that is an AV pacing. And we're going to use pacing to restore an adequate heart rate and rhythm back to the heart or the body, right? This so we get better. We're going to improve our output, right? I made a note on some of the side effects on that. We're going to go on. Okay. All right, let's just go on. Okay, so AV pacing, two pacer spikes, one in front, one followed by a P wave, the second one, that. Two leads, atrium and ventricular. Sometimes it can just do one. Sometimes it just might be the atrium firing. The ventricular responds appropriately, so the ventricular lead does not need to fire, and vice versa. The atrium can, atrium, and this does, or I'm sorry, guys, I had a brain fart there. Let's move on. All right, so let's talk about conditions that need pacemakers. Absolute needs them, must have them. Patients with sick sinus syndrome. Symptomatic bradycardia. These are slow rhythms, okay? These rhythms decrease, you have a decreased cardiac output, and thereby you can have all those forward effects that go on, right? Fatigue and all that, and then you're going to have an increased heart rate, more tissue damage, and just keeps going on. So patients that need pacemakers, sick sinus syndrome, symptomatic bradycardia, and then tachybrady syndrome. Now that's where that heart rate goes too fast or too slow. So they go in there, they're fast and then they slow down. They're fast and go slow down. And then your atrial fibrillation with SA node dysfunction. Okay, and like I said, these two in here are really kind of the same in a sense. If you treat the fast heart rate, it goes too slow. If you don't treat the slow heart, it goes too fast. So this way you can work on both together. Okay, it's going to let us give medications to slow down the heart rate, and then yet it's going to keep that the heart rate up through the pacing. Complete heart block, third-degree heart block, and then patients with incomplete or prolonged QT syndromes, and then cardio revascularization therapy. These two I'm not going to talk about. So pacemaker settings, the rate's going to refer just exactly what at, how many pulses per minute are we going to use to keep the heart rate up. So generally they'll have like a low limit and a high rate and a high limit and a low limit. 60 I see is frequent, and then sometimes I see them as 50, but I don't think rarely do I see a pacemaker at a low limit set below 50. The amplitude or milliamps, this is the amount of, this is your, how much shock, I'm sorry, how much do we need to deliver to get the pulse to capture, right? That's our milliamps. So it's how much are we going to shock them with? Okay, some need a little shock, some need a bigger shock. Stimulation threshold. I'm going to skip over that one, guys. Sensitivity is our next big one, and this one is going to be our millivolts. So milliamps is going to be your output or your amplitude, and sensitivity is going to be your millivolts. Okay, and one way to, when you think about your sensitivity, we got to think about it, it's like looking over a fence. The higher the fence, the less sensitive it is. Okay? So the higher the number, the less sensitive your pacemaker is. So if you need to, I don't want to confuse you. The higher the number, the less sensing. Okay? The lower the number means you're sensing more. Okay? So when you have a milliamp of 1, you're not going to sense it as much as you would have at 0.5. So it's like it's opposite of what you would think. I guess that would be the best way to think about it. It's opposite. You think if you're turning it up, you're going to get better sensitivity. No, you're decreasing it. So that's a really awkward one. I don't know who decided that was the best way of doing that. But anyway, the two ones that we're going to focus on here is mostly going to be your milliamps and your millivolts. Look this over. I really don't want to go into this. This can get really complex. This is just this just talks about the different types of pacings. So when we say DDI, or DDO, or, that's going to refer to each of these, and you can go in there, right? And then you can see what chamber's being paced, what mode it's on, the function, and any antiarrhythmic or tachycardia. Yeah, so look this over when you get a chance, because I really don't want to go into this one. Okay, let's go ahead and look at some nice pacing rhythms with no problems going on. In that first one here, this top one here, this is atrial pacing. This may look like a QRS because it's got a little bit of a wide thing here, but this is actually your pacer spike. So what's happening is that the rate's low, or it's sensing the problem. Just your rate is low. Your P wave isn't, your atrium's not doing it. Your SA node, AV node, SA node, I'm sorry, SA node isn't doing its job. Went to sleep. So the pacemaker is going to spike and wake it up. So atrial pacing, what you're going to see is you're going to see a pacer spike followed by a QRS. And then it's going to have its normal, your P wave, and it's going to have its normal QRS. So here, pacer spike followed by your P wave, normal QRS. And if you look at this, this is what we would call 100% AV or atrial pace, because there's a atrial pacing before every single one. 100% atrial paste. The atrium's doing its job, you wouldn't see that. This, so you might see atrial pacing, intermittent atrial pacing. This second one, let's go to the ventricle pacing. So I got these labels kind of backwards. So the ventricle pacing, it's where the atrium fires. It's doing its job. There's a P wave right there. We got P's going on. Look at that. But the ventricle decided it's not gonna do its job. It's gonna wait, be delayed, and not respond to that. So when that happens, the ventricle pacing, that V wire down in the ventricle is gonna fire. And that's where, this is what it looks like. This is 100% V paced here, okay? Because there's a pacer spike before every QRS. And one thing to note is that this QRS is a little bit wider, right? When it's ventricle paced, because it's a slower conduction through that ventricle. And sometimes this can actually set your bedside monitor alarm off saying it's VTAC. But know that if you have a patient with a pacemaker, I mean, obviously the first thing you want to do is to check that patient, but if their patient's fine, then just check the monitor, because it may not be reading your V pacing, your pacer spikes. It's not identifying it. This one right here is what we call AV pacing. And this is because both the atrium and the ventricle need assistance, okay? So you can see right here, here's your pacer spike, followed by your P wave. Ventricle didn't respond when it was supposed to, so the ventricle one paced, and it follows your QRS, and your QRS follows. And if you look, there's one for every one, so this is 100% AV pacing. So atrial pace before the P wave, V pacing before the QRS, AV pacing, look for the two spikes right there, for your P and before your QRS. All right, temporary pacemakers. These are two different kinds of temporary pacemakers here. And I put them up here just because this is one I typically see here, but this one actually is a better view of what's going on how to make your adjustments. So when we have a patient who needs a pacemaker, and we need to start pacing them immediately, and it may, instead of externally pacing them, which is very uncomfortable, we're going to put in a temporary pacemaker, and this is called a transvenous pacemaker. And typically what they would do is they would go up in through the subclavian, or up in the subclavian in the neck, and they're going to thread that down into the heart, and they're going to put that lead in there, and then it's going to come out, and then it's going to connect through our wires right to our pacemaker box, and then we're going to pace them from this. Okay. This one here actually just shows that it just shows your milliamps, your sensitivity. So as you can see, we have the capability of controlling the rate. So the doctor's going to let us know where they want the heart rate at. And then we are going to work with the doctor on the milliamps and the sensitivity, right? So how much shock do I give them to get the heart to respond, right? And how much sensitivity, how sensitive is the heart to that, to the shock? Okay, is it looking over the fence, right? And obviously we want to keep it at the lowest settings possible. So here's so this is epicardial pacing, and what you're going to see is epicardial is going to go through the chest wall. This is an open heart patient here on the left, and on the right you can see this is the pacemaker that we use, but what's going to be different is these cables and how these cables go into the heart. Okay, well, this is just the single wire coming out. You can see hooking into here. We have through the heart, we're going to have the pacer wires. During surgery, they're going to place the pacer wires through the chest wall into the heart. And they've got a little hook on them that's going to hook in there just a little bit, and then the wires are going to come through that chest wall, and they're going to have it tied and secured right here. And then you got the two small wires you can see there and there. And those small wires have got little metal nubs on the end, and they're going to go into this device here, which is where our pacer, this is our pacer cable. And they go in, you screw it down with these little knobs on the sides, and then this cable here is going to in up here. So you got actually two spots up here, one for the atrial pacing and one for the ventricular pacing. Okay, so this is something you're going to see with the open heart patients. And then they'll use that in case their cardiac output goes down post-operatively. They got to reduce low cardiac output. So we want to, one of the ways we can increase the cardiac output is by increasing the heart rate. And that's how we can do it with those patients. And then these pacer wires are removed usually the day 1 or 2 days before, the day of discharge in the morning, or the day before that. But and they just untie and they just pull right out through the pull right out through the chest wall. All right, let's talk about pacing errors. We have a couple things. We're going to talk about failure to sense and failure to capture. Failure to sense or undersensing of the pacemaker occurs when the pacemaker fails to detect the underlying rhythm or what's going on in the patient's own heart rhythm. So it doesn't see it, or it's not identifying it, right? So it's not sensing it properly. And what you're going to see is that pacer spikes are going to just occur wherever they want. They're just going to kind of come up randomly, all right? So they're going to fire at the wrong time. Pacer, it's not sensing it. It just doesn't sense it. It doesn't sense what's going on. It doesn't see what's going on. The fence is too high, so it's just guessing at it. Okay, and you can see here what's going to happen, and what you're going to see on a monitor is you're going to see, well, here's your own underlying rhythm here. Then you got a pacer spike with a right, and here, and then look, you got a pacer spike here. It just says, hey, let's just do it here. And then another pacer spike here. So it's not sensing what's going on in this rhythm, in this complex, and it's just firing whenever it thinks it's supposed to be firing. So that's a failure to sense. So how do you fix it? Well, to fix it, we're going to adjust the sensitivity. And how do we adjust the sensitivity? Turn up the control. We're going to turn up the sensitivity control. By turning it up, we lower the fence. Failure to capture. So failure to capture is a little bit different. The pacemaker is doing its job. It's sensing everything. It's firing, but guess what? The heart is not responding. The myocardium is not responding. And for whatever reason, and on, so it's not depolarizing. It's not responding. So here's a good example of that. You've got your pacemaker, you got a V pace pacer. This is V pacing because there's a ventricle. You don't see any P wave. Pacing here, and then look what happens. It fires, and the ventricle says, nope, taking a break. Nope, still sleeping. Okay, it fires again. Yeah, okay, I'll think about getting up. Fall back to sleep. No, not going to do anything. So this is a failure to capture, and this is a very dangerous one because what can happen is in this one here, it needs to be, your pacemaker needs to be adjusted. Okay, they're going to need to adjust the milliamps in this patient to stimulate the ventricle to fire. This one is not the worst one. You're going to have a decreased cardiac output, but you still have ventricle activity in here. This is an emergent right here. If you see this, you're going to immediately turn up your milliamps, and it's in red for a reason. If you look at this, there is no ventricular response going on anywhere in this rhythm. All you see are those pacer spikes. This is an emergency. This is asystole with pacer spikes. Nothing's going on. Turn up your milliamps. All right, let's move on to balloon pumps. That's enough about pacemakers. So intra-aortic balloon pumps, when you have patients that are severely compromised, such as that can happen following an MI or in cardiogenic shock, they need additional cardiac support. And one therapy we can use is putting them on a balloon pump, an intra-aortic balloon pump. And the goal of the intra-aortic balloon pump is to improve the ventricular performance of the failing heart by facilitating an increase in the myocardium oxygenation supply and decreasing the myocardial oxygen demand. So what we're saying is that we're going to increase the oxygen demand of the heart while increasing supply to the heart. And this is going to help the heart recover and rest a little bit. Indications: acute MI, okay, cardiogenic shock. These are the two really common ones right here. You can see it in left ventricular failure, but it's, I don't know if anybody's been put on that. Those patients we have usually sent out, but you can put them on left ventricular failure to help support them prior to surgery if they need it. And then you can have that refractory ventricular arrhythmias that they need additional support for. Acute mitral valve, SPT, cardiomyopathy. I don't see these very often. Cardiac surgery. So a lot of times what we're going to see is they're going to come in with an acute MI. There's going to be significant damage. The heart is really stunned quite a bit and needs time to recover and help recovering. So we'll put them on that, the balloon pump. And then they may or may not end up having to go to open heart surgery. If they do go to cardiac surgery, they'll be on the balloon pump when they go to surgery. They stay on the balloon pump. The balloon pump stays in during surgery. And then once the patient comes back from open heart surgery and they are stabilized, then we'll remove the balloon pump after that. Contraindications: aortic regurgitation, aortic dissection, stenosis. These you never want to use a balloon pump in. If you've got like a dissection, you can just totally rip that whole side off because you're inflating a balloon up in there. And then things that need to be conditions that are need to be done very cautiously are abdominal aortic aneurysms. You really don't want to use it in there. Tachycardic arrhythmias. If the heart beats too fast, that balloon pump is just not going to be effective at all. And then any type of major arterial reconstructive surgery. You're running a really high risk with these. So really, I don't think I've ever seen patients with any of these conditions on a balloon pump. Mostly it's acute MIs that are in cardiogenic shock that need to go to open heart surgery. And we use the balloon pump to help support them during that time. So let's take a look real quick at the balloon pump in itself. So let's start with this bottom slide here. So here we have the heart and the balloon. This is the balloon, and it's going to sit right below that aortic arch, about 3 centimeters down. It's going to go all the way down. It doesn't fill the entire, but what they do is they're going to go through the groin. They're going to put that sheath in just like they would with a heart cath. And then they're going to put this balloon up in there, and that balloon actually is filled with helium. So that whole thing inflates and deflates, and it's pretty good size when you look at the diameter. So here it's going to show where it's inflation. The important thing to remember is that when inflation and deflation occurs, and it's a very big thing because you can actually cause significant damage to the heart and if you are inflating and deflating at the wrong time. So let's look at inflation. Inflation is at the onset of diastole. That's when the heart is filling at rest. And what's happening? The valves are closed, right? It's not trying to push the blood out. So the valves close, the balloon fills up. And the effect that this has is it's going to give us increased coronary artery perfusion, right? So that blood, it's going to help push that blood back into the coronary arteries when it inflates. The deflation, on the other hand, happens just prior to the end of diastole. So just before systole, when the heart, the valves are opening, getting ready to open, and the muscles, the ventricles getting ready to contract, we want to open it up. Because if we don't, what we're going to be doing is trying to pump blood out, right? Squeeze blood out while that's inflated, and now you've got a total blockage going on here. That's not what you want. So you want to decrease that balloon once you want it to deflate prior to the squeeze of the heart or prior to systole, okay? And what this is going to do, it's going to create a few really good effects here. So because blood's not filled in there, right? So when it deflates and the heart squeezes, this actually causes a decrease in the afterload. So the heart doesn't have to squeeze very hard. There's almost like no resistance, okay? So it just kind of free flows out. Little squeeze and we get a lot out, okay? This in turn is going to cause a decreased work on the heart. The heart doesn't have to work as hard, thereby it doesn't have to use as much oxygen. The oxygen demand and consumption goes down, and ultimately this increases your cardiac output. Okay, so you have decreased afterload and decreased afterload and increased cardiac output. So let's look at the waveform up here. This is a typical waveform in this top section here. You can see how it correlates with the rhythm down here and everything. This is our unassisted, so this is our underlying, no balloon going on in here. This spot right here, that's that dicrotic notch that we talked about. And that dicrotic notch is going to indicate to us the closing of those valves. That right, the beginning of diastole. That's where diastole starts. Okay, so here's our squeeze, valves close, right? There's your systolic, valve closed. Here's your diastolic, right? Filling. So then, as we go on, it fills up, right? Or it's squeezing out. Squeezing out. There's your systole. You see where your dicrotic notch is? That's right here. So that balloon, this is your balloon. It's going to inflate just before that dicrotic notch, or I'm sorry, right after that dicrotic notch, right there. Right? So the valve's open, the balloon inflates. And this is your augmented pressure. This is where your coronary artery, I'm sorry, I'm tired. I did that backwards. This is your inflation of your balloon. This is your deflation. Okay, so your balloon inflates, right in here. Yeah, systole. Yeah, that's your contraction. Duh, stupid me. Okay, I see what I did wrong. I was right. This is your systole, this is your diastole, dicrotic notch. This is where the valves are closing, right? So when the valve closes, the balloon inflates, and that's what this represents right here. And right here is the beginning of that dicrotic notch again, right before we have our balloon deflation. All right, I'm going to stop on that because I'm going to just keep going. So anyway, the bottom line is it's going to decrease the afterload, decrease workload on the heart, decrease O2 consumption, and increase cardiac output, thereby allowing the heart to rest. These are some of the effects that the balloon pump has on these areas. So on the aorta, it's going to decrease the systolic pressure and increase the diastolic pressure. The left ventricle, you're going to have a decreased pressure, decreased diastolic pressure, decreased volume, decreased wall tension. So you can see how it's really just decreasing all the workload on there. And then the heart, you have a decreased afterload, decreased preload, and you have an increased cardiac output. And again, increased coronary artery perfusion. How do we care for a patient with a balloon pump? These patients are one-to-one care. They need to have the nurse there at all times. A patient can sit up, things can go wrong very quickly. So some of the things that we're going to do is we're going to be checking their vascular assessment every 2 hours or more frequently. A lot of times we're pretty much doing it hourly instead of 2 hours. But this says 2 hours. I don't know what standard that is. St. Mary's, it's Q1 hour. So we're going to look at the color sensitivity, sensation, and movement of their extremities. We're going to look at the pulses. We're going to check for the quality. We're going to make sure they have a pulse, that nothing has, if we lose that pulse, we need to be very concerned about that. Notify the doctor immediately. A clot can develop in there, and we can have a significant ischemia to that leg. We also want to look for a diminished radial pulse, left radial pulse, and it's very specific because coming off of that at the tip of that, at the aortic arch right there, right above that is the artery that feeds that left radial and that left arm. So if you lose that pulse, it can mean that the balloon has shifted and gone too high and it's blocking that artery. So you can end up with a ischemic heart or ischemic arm. And if that's the case and you lose a pulse in that, you need to call and get a stat chest x-ray to check the placement of the balloon pump. We're going to administer anticoagulants per physician's order and observe for any signs and symptoms of bleeding. Okay, and that's going to be anywhere, and especially around the groin site. Monitor coagulation in all of our blood functions, our CBC, cardiac, our troponins, all of that. We're going to encourage the patient to deep breathe to make sure that they don't get any atelectasis or develop any pneumonia if they're going to be down for several days with this. And then we're going to maintain optimal patient positioning. And that means that we're going to keep that leg straight at the groin area. We're not going to be bending it, okay? It's going to occlude, clamp off that balloon, and we're not going to get inflation and stuff. So we want to make sure proper body alignment. So what we're going to do is we're going to log roll them. They're going to need to be log rolled and frequent turning. Also, what we want to do is make sure we got adequate pain medications. A lot of patients have chronic back pain and they can get very uncomfortable, start getting restless and stuff. So we always want to make sure we have adequate pain management on board to help with any issues with their back and discomfort that they might have. As far as the head of the bed, you do not want to raise the head of the bed up where they're bending at the hip, right? But what you can do is to get them into a reverse Trendelenburg. As long as you're keeping body alignment in that groin area, you can raise it up so they don't feel like they're laying on their head all the time and laying upside down. And then, of course, we want to monitor the urinary output. If the urine output goes less than 30 mLs an hour, it can indicate that the balloon pump has come out and pulled back some and has gone lower, right? And has occluded the renal artery. So then again, you want to get a stat chest x-ray. And then we want to perform and promote some range of motion on the unaffected extremity. We're almost there. 5 more slides, almost done. Okay, LVAD assist device, left ventricular assist device. These are kind of cool. Just be aware of them. I'm not going to go over too much with it. Okay. So what the blood, it's going to do when the left ventricle can't pump that blood out on its own, it's going to need something to help get it out, right? So say the filling isn't the problem, it's contract, right? This contraction is a problem and it's out. So what they're going to do is they're going to put this into the left ventricle. It looks really medieval if you ask me. And it's going to go into connect into the pump unit here. Okay, you can see that's here, and then the battery and all that is on the exterior. And then it's going to bypass around that heart and go right up into that aortic arch. And what it's going to do is going to pull blood from the ventricle, bypass it, and put it right back up into here. So it's going to kind of do it backwards. So instead of going from here and up this way, it's going to help pull blood the opposite, right? So that's your LVAD. Impella. This one I like. I like this better than the LVAD. This is cool. Open this link and watch it. It's just a 1-2 minute video. It's really cool. It shows you how it works. But what's happening is they put this into that ventricle, and it has this little generator and this little motor on it, and it pulls some of that blood up and out of that left ventricle, thereby relieving the left ventricle of the overloading. It helps to get the blood out and increase your cardiac output. Lastly, cardiac transplants. I'm not going into a great deal of detail, but enough for you to be familiar with. So approximately 5,000 heart transplants are performed annually worldwide. Really, that's not a lot. I thought it would be higher than that, but that's just not that long, a lot. Life expectancy of heart transplant patients, 82% lived for 1 year, 70% for 5 years, and only 50% will live 15 years with the heart transplant. A couple of different ways of doing transplant. Um, you're going to look at they can either take all of the heart or part of the heart. So what we're going to do is we're going to look at the bicavinal and the biatrial. So the bicavital maintains the donor's right atrium. So the right atrium goes. It's a longer surgery, but there are less complications such as arrhythmia, dysrhythmias. Biatrial is shorter, has a shorter ischemic time, and is an easier procedure to do. And I'll show you why. So here you can see why. Okay. And this one here, it's a shorter procedure. Just look at it. Just cut it all out. Take it out, put a whole new one in, and connect all the vessels here. So a shorter procedure here. This one's a longer procedure because look what they're doing, right? They're keeping part of that atrium in, and then they're connecting all of the rest of this in. So part of the atrium is being maintained. Okay. Complications from heart transplant. Rejection, obviously organ rejection can be a complication. You have risk of infection that can be either immediate post-operative or related to immunosuppressive therapy where it suppresses that immune system to keep the body from rejecting the heart and making you more susceptible to infections. So you got to watch that. And immunosuppressant therapy in itself can cause some complications such as renal dysfunction, can cause hypertension, and that's not good when you're trying to heal from that because the pressure gets too high, you can have leakage around the sutures, and that's not what you want. You can develop diabetes from immunosuppressant therapy, hyperlipidemia, osteoarthritis, and malignant neoplasm. I don't think I've ever seen that. And then, of course, another complication is the psychological effects or the emotional adjustment to having the heart transplant in itself. All right, guys, that's it. That's it. I hope everything's fine. Go back to those, the heart failure and right and left side of heart failure, systolic, diastolic, and look at those videos. Like I said, they're really good. And then if you get a chance, like I said, look at that real quick one on the impella. That's a really nice one to see, and I just think that's great. And I hope this was helpful. Thank you.